Bacterial sepsis following pregnancy. Green Top Guideline number 64B, April 2012. Background and introduction. Sepsis may be defined as infection plus systemic manifestations of infection. Severe sepsis may be defined as sepsis plus sepsis-induced organ dysfunction or tissue hypoperfusion. Septic shock is defined as the persistence of hypoperfusion despite adequate fluid replacement therapy. Sepsis in the puerperium remains an important cause of maternal death, accounting for around 10 deaths per year in the UK. Severe sepsis with acute organ dysfunction has a mortality rate of 20 to 40%, rising to around 60% if septicemic shock develops. Table number 1. Risk factors for maternal sepsis as identified by the confidential inquiries into maternal deaths. Obesity, impaired glucose tolerance, or diabetes, impaired immunity or immunosuppressant medication, anemia, vaginal discharge, history of pelvic infection, amniocentesis and other invasive procedures, cervical cerclage, prolonged spontaneous rupture of membranes, vaginal trauma, cesarean section, wound hematoma, retained products of conception, Group A streptococcal infection in close contacts or family members, and Black or minority ethnic group origin. What are the common organisms causing sepsis in the puerperium, including hospital-acquired infection? The major pathogens causing sepsis in the puerperium are Group A Streptococcus, also known as Streptococcus pyogenes, Escherichia coli, Staphylococcus aureus, Streptococcus pneumoniae, and methicillin-resistant Staphylococcus aureus or MRSA, Clostridium septicum, and Morganella morgani. Group A Streptococcus is increasingly causing invasive infections worldwide and was directly responsible for 13 of the 29 maternal deaths from infection in the UK during 2006 to 2008. Gram-negative bacteria that produce extended spectrum beta-lactamases or ESBL are an increasingly common cause of co-amoxiclav and cephalosporin-resistant urinary tract infections. Management. What are the likely causes of sepsis outside the genital tract and how might they be identified? A general history and examination should be carried out to try and identify the source of sepsis. Women should be assessed clinically, and if unwell or with dehydration or vomiting, admission should be considered. Mastitis, urinary tract infection, pneumonia, skin and soft tissue infection, gastroenteritis, and pharyngitis are likely causes of sepsis other than the genital tract. Rare causes include bacterial meningitis. Mastitis. Mastitis is easily overlooked clinically but may lead to breast abscesses, necrotizing fasciitis, and toxic shock syndrome. Immediate referral to hospital is indicated if the woman with mastitis is clinically unwell, if there is no response to oral antibiotics within 48 hours, if mastitis recurs, or if there are very severe or unusual symptoms. Urinary tract infection. Gram-negative bacterial infections are particularly associated with the urinary tract. Acute pyelonephritis should be treated aggressively. Although not all women may warrant hospital admission, those with signs of sepsis, those who are unable to remain hydrated, and those who are vomiting should be admitted. Identification of urinary sepsis is primarily clinical, but the presence of leukocytes, protein, and blood in a midstream specimen of urine may be suggestive of current infection, and a specimen should be sent for culture. Pneumonia. Hemoptysis may be a feature of pneumococcal pneumonia. Severe hemoptysis and low peripheral white cell count suggest PVL or Panton-Valentine leukocidin-associated staphylococcal necrotizing pneumonia, which has a mortality rate of more than 70% in young, fit people. Identification of the cause of pneumonia is by submitting a sample of sputum to the laboratory for culture. Skin and soft tissue infection. Any woman with suspected bacterial sepsis should be carefully examined for skin and soft tissue infection, particularly looking at intravenous cannula or injection sites and cesarean or episiotomy wounds. Swabs should be taken of any discharge. If drains, vascular access devices, or other indwelling devices are suspected as the source of infection, they should be removed as soon as is practicable. Skin and soft tissue infections are particularly associated with toxic shock syndromes. Recurrent abscess formation, including labial abscesses, is a feature of PVL-producing staphylococci. Septicemic seeding of streptococci from a uterine focus may give rise to a secondary focus in the limb, simulating a venous thrombosis. Early necrotizing fasciitis occurs deep in the tissues. Therefore, in early necrotizing fasciitis, there may be no visible skin changes. As the necrotizing process ascends to the skin, late infection produces blisters and obvious necrosis. The cardinal feature of necrotizing fasciitis is of agonizing pain, typically necessitating increasing amounts of strong analgesia, culminating in use of opiates. Women with suspected thrombosis who are systematically unwell with any features of sepsis should be examined very carefully. Gastroenteritis. Salmonella and Campylobacter rarely cause severe systemic infection and should be managed symptomatically unless features of bacteremia are present. Diarrhea and vomiting may be features of toxic shock syndrome together with features of profound sepsis. Clostridium difficile is rare but increasingly found in obstetric patients. Pharyngitis. Most cases of pharyngitis are viral, but approximately 10% of cases in adults are attributable to group A Streptococcus. If 3 of the 4 CENTOR criteria, fever, tonsillar exudate, no cough, and tender anterior cervical lymphadenopathy are present, treatment with an antibiotic is appropriate. Infection related to regional anesthesia. Spinal abscess is a very rare complication after regional anesthesia in obstetric patients. The usual organism responsible is Staphylococcus aureus with streptococci, gram-negative rods, and sterile specimens accounting for 15% each. What should prompt recognition of sepsis in the puerperium? All health professionals should be aware of the symptoms and signs of maternal sepsis and critical illness and of the rapid, potentially lethal course of severe sepsis and septic shock. Suspicion of significant sepsis should trigger urgent referral to secondary care. Sepsis should be considered in all recently delivered women who feel unwell and have pyrexia or hypothermia. The common symptoms of sepsis in the puerperium include fever, diarrhea, vomiting, abdominal pain, generalized maculopapular rash, staphylococcal or streptococcal sepsis, offensive vaginal discharge, and signs of infection in cesarean wounds. Clinical signs suggestive of sepsis include one or more of the following: pyrexia, hypothermia, tachycardia, tachypnea, hypoxia, hypotension, oliguria, impaired consciousness, and failure to respond to treatment. These signs, including pyrexia, may not always be present and are not necessarily related to the severity of sepsis. Conjunctival suffusion is a classic sign of toxic shock syndrome. Agonizing pain out of proportion to the clinical signs suggests a deep infection, and necrotizing fasciitis or myositis must be considered. Mastitis must never be overlooked. Abdominal pain, fever greater than 38 degrees Celsius, and tachycardia greater than 90 beats per minute in the puerperium are indications for intravenous antibiotics and senior clinical review. Non-steroidal anti-inflammatory drugs or NSAIDs should be avoided for pain relief in cases of sepsis, as they impede the ability of polymorphs to fight group A streptococcal infection. Since non-steroidal anti-inflammatory drugs or NSAIDs significantly impede the ability of polymorphs to fight infection caused by group A streptococcus, they should be avoided for pain relief in cases of sepsis. Table number 2. Common symptoms of sepsis in the puerperium: fever, rigors, persistent spiking temperature suggests abscess. Beware, normal temperature may be attributable to antipyretics or non-steroidal anti-inflammatory drugs or NSAIDs. Diarrhea or vomiting may indicate exotoxin production or early toxic shock. Breast engorgement or redness, rash, generalized maculopapular rash, abdominal or pelvic pain and tenderness, wound infection, spreading cellulitis or discharge, offensive vaginal discharge, smelly, suggestive of anaerobes, and serosanguinous, suggestive of streptococcal infection. Productive cough, urinary symptoms, delay in uterine involution, heavy lochia, general non-specific signs such as lethargy and reduced appetite. Some cases of sepsis in the puerperium may present initially only with severe abdominal pain in the absence of fever and tachycardia. Any widespread rash should suggest early toxic shock syndrome, especially if conjunctival hyperemia or suffusion is present. A generalized macular rash is present in most cases of staphylococcal toxic shock syndrome, but in only 10% of cases of streptococcal toxic shock syndrome. What are the appropriate triggers or features of sepsis in the puerperium that should prompt hospital admission? Community carers should be aware of the importance of early referral to hospital of recently delivered women who feel unwell and have pyrexia, and should be aware of the possibility of sepsis in the puerperium. If sepsis is suspected in the community, urgent referral to hospital is indicated. Red flag signs and symptoms should prompt urgent referral for hospital assessment, and if the woman appears seriously unwell, by emergency ambulance. Pyrexia more than 38 degrees Celsius, sustained tachycardia more than 90 beats per minute, breathlessness, a respiratory rate of more than 20 breaths per minute is a serious symptom. Abdominal or chest pain, diarrhea and or vomiting, uterine or renal angle pain and tenderness, and woman is generally unwell or seems unduly anxious or distressed. Early presentation of sepsis, less than 12 hours post-birth, is more likely to be caused by streptococcal infection, particularly group A streptococcus, and severe continuous pain suggests necrotizing fasciitis. Infection must also be suspected and actively ruled out when a recently delivered woman has persistent vaginal bleeding and abdominal pain. If there is any concern, the woman must be referred back to the maternity unit as soon as possible. What are the indications for admission to the intensive care unit? The presence of shock or other organ dysfunction in the woman is an indication for admission to the intensive care unit or ICU. Table number 5. Indications for admission of the woman to the ICU as adopted from Platt and Ray of 2008. System: cardiovascular. Indication: hypotension or raised serum lactate persisting despite fluid resuscitation, suggesting the need for inotrope support. Respiratory: pulmonary edema, mechanical ventilation, and airway protection. Renal: renal dialysis. Neurological: significantly decreased conscious level. Miscellaneous: multi-organ failure, uncorrected acidosis, and hypothermia.